Thank you very much for this kind words and introduction. Thank you, ESHRE, for this invitation. Yes, indeed, we will move on, no declaration. And everything, my dear friends, started with this. Ariana was my director for my dissertation thesis in a program of a master in science in advanced gynecological training, supervised by my professor Nazar Anso. And we worked about 2 years to find out a little bit more for the OPU. So based on this, we move on. I was as well invited, and then in 2019, finally, we have the first guideline, maybe in the world, about the OPU, partially from the United States, but mainly in the European sort of context. Because it was based, as Ariana said, in great proportion on the expert opinion suggestions after a consensus that we had. I got a lot of experience in Delphi, and then we moved on to the next step, because, yes, OPU, fine, but we need the pregnancy, so we need to go to the embryo transfer. So we presented in 20 the second Delphi, based on experts, again in the Europe, and the results of this I have put as an X. So you could see the results at the end of this presentation. So since then, it took us another 2 years, not only because of the coronavirus pandemic, but because when we suggested to the human reproduction all the evidence that we collected, it seems that we were over-enthusiastic about the volume of the information, the details. So they asked us to rewrite all the paper again, a little more simplified. So all what you will see today, it will be based on this simplified paper, which I will suggest that you can print out or get alongside with this presentation for the colleagues physically present and those that they will see us from the web. So I move on. So I will emphasize on the ultrasound quality. The main, because I have to run a little bit faster now, the main thing is that you can read the evidence and what we have done about these conclusions. But this paper actually suggested at bullet points up to 30 to 31 standards about the embryo transfer. For these, 8 are referred on ultrasound. And I will expand them, so we could even have 30 ultrasonographic related standards for embryo transfer. I will show you a number of videos, and we will all together will evaluate critically about these videos about these embryo transfers. And I will emphasize about the training and the certification, and I will show you a very interesting case of difficulty, because we need to show the good ones, but we need to show the difficult ones. This is top quality practical ultrasound course today. So allow me to point out within the paper these areas that are related to the ultrasound. So basically, yes, we need to have a evaluation, a gynecological evaluation, but we should start now to correlate what we see before even the diagnosis, before the protocol, what could be the difficulty or not, or easiness about the embryo transfer. So yes, we should have again a gynecological and vaginal estimation evaluation, but we need to be sure whether we have adenomyosis or not. The malformation, usually we get it, the polyps most of the times, and the status of the ovaries. Now, during the process of evaluating all this, it's something rare, but we can evaluate the cervical catheterization ability. And today we had the hycosi and the hyphosi. Yes, you can get certain information about the catheterization, because if you use, for example, intracervical catheters, you can assimilate like a flexible, let's say, embryo transfer catheter. So you know already whether this cervix is kind to you or not. There are cases where you don't even think about what will be the end for embryo transfer, either because you don't know what will be the future, or because you work in a team that there are many people, so you do one part of the job, but we don't consider the last one who will complete it. So office hysteroscopy if you need it for anatomical reasons, or if you have ladies that they had stenosis of the cervix, you may need to recheck a little the cavity of the intracervical canal, because you can have this sort of strange internal stenosis that you may be able to detect early, and I will show you this at the end of the presentation. The second thing that we have to have a standard, and all of us will agree on this, I hope, is that we need to have good instruments. And when I'm saying instruments, like the piano, you need to have a very good ultrasound machine. What happens in the IVF in the reality? Think about it. There are more obsolete, old models, all the machines that they are to throw in the bin, and these are in these centers where they do the embryo transfer. Why? Because they consider so far that the ultrasound machine needs just to show the end of the embryo, endometrial cavity. So it helps partially. No, for the embryo transfer, as for the OPU, as Ariana said, we need to have top models, very good models of machines. The third thing is the positioning of the patient. Because I will talk to you in a moment, I forgot the assistant. And the assistant is very important for the embryo transfer. Yes, you are not the only one, you have an assistant. So the assistant needs to be evaluated, trained, explained, be as a team member. The assistant is not somebody just holding a probe and having the ultrasonography field just static. He is very, very important to facilitate this maneuver. Now, another place of standards are the positioning and mainly the use of proper gynecological specialized couches. These couches can do what? They can do the tilting of the pelvis. You don't have lithotomy. You don't have to have the women flat. They can see as well. They feel much better. You examine them easier, and you have more ways of putting your speculum in examination. So you have bigger and easier ways to manipulate the anatomy in order that you facilitate your catheterization. The bladder is a very good thing if you work only with flat surface, because then you fill the bladder pushes the uterus, and you have alienated the cervical canal with the axis of the endometrial cavity. But if you use this kind of couches, you may not need so much of overfilled bladder, certainly not for a retroverted uterus, because then you do worsening. Don't forget that when you tilt the patient backwards a little bit, only with the pelvis, I will show you an image in a moment, the bowel goes backwards. Yeah, the ovaries go backwards. So with this only simple stuff, you have improved the icogenicity of the anatomy of this woman, just doing this. Plus the fact that the uterus is with the gravity going backwards. I'm talking naturally for the normal uterus and the normal anatomies. The ultrasound can help you estimating potential during the stimulation or even before of contraindication, mainly for the OHSS. The tubes as well. So all this is kind of a way to assess whether you will do or not the embryo transfer. I mean, if you have fluid, if you have all this, you need to check them. So there are standards that we need to check not only the endometrial cavity, but all the anatomic areas all around. Now, taking the time to set and making this optimization is essential. We do the embryo transfer as fast as we can, we say, but actually we should give the time to optimize the image. I had a colleague in Greece that have done in 7 minutes, literally, 3 embryo transfers. I mean, these 3 women were in 3 different couches. I mean, it's Gonzalez. It's impossible that you improve the image. I don't know whether it was positive or not, but we shouldn't exaggerate. You need to take time. It's the moment of truth. It's the moment of the glory moment that you help this woman, and this woman has expectations of you to have some sort of a good conditioning embryo transfer technique. It's not hurry. That's not nice. Certain, we need to bring at last 2023 the fact that we need to document and we have photos and cine loops. I'm a laparoscopist. When you train laparoscopy, not only do simulators, but you record what you're doing, and then you go backwards. So why we haven't done so far? In any unit that I have been, and units that are 4,000 or 5,000 stimulating cycles, none have ever record something. So it's essential for you, for the training, and I will mention other reasons. So it's nice to have a set where you can have the cine loop 15, 30 seconds, or you can take nice photos. These two in yellow are indirectly related, but I will explain to you. One is very important, saying that if you manage to have this bubble or this fluctuation of mini pixels of the fluid with the embryo near to the fundal part of the endometrium, approximately less than 10 millimeter, it seems that the destiny of this pregnancy is a little higher, or significantly higher for some. So yes, we need to bring these embryos as close, but we need to measure, we need to show this. The other two is important because, first, we have forgotten with the time to evaluate the myometrium. So there are difficulties, of course, to diagnose adenomyosis, but even if you have focal or diffuse adenomyosis, there are indirect and direct signs. These kind of women may not have as favorable embryo transfers. So it's a new parameter now that we can check during the process. So it's not just the protocol or the product AB, is we have forgot to subgroup these women with normal uterus, with possibly abnormal uterus with adenomyosis, or other kind of problems like fibroids, Cézanne sections, and so on. The last one, it talks about the timing. So this refers to the time for the moment that your catheter is starting to be in the cervix, and then the moment that the egg or eggs have been released. How fast do you do that? Do you have an idea? Well, some people know that. There's a couple seconds, 15, 20. We wrote that this approximately 30. But we have to evaluate this, whether the delay or not and is negative. And there is evidence, but we have to confirm this. It's not just some brilliant people that they take time in their life to do all these things and then we don't care about that. So there are standards, because these potentially affect slowly your effectiveness. So there is a difference between the pre-embryo transfer ultrasound assessment and the moment that you do the embryo injection. So these just the bullet points, so if you want to reflect on your own practice or in your own unit, you can just think what you do or what you could do about all this. Now we develop further the positioning. I mentioned all this. I have given the list so you can a little bit facilitate it. So another thing is the position of ultrasound. I'm talking about basic stuff. I mean, why the ultrasound machines are on the other side of your dominant hand? From the side of the dominant hand. I mean, if you are right-handed, the machine is the right side, you will never have a possibility yourself to improve your image. Or you will ask somebody else to do, but it's strange. So we need to agree that if we're dominant, the machine needs to be the non-dominant hand, because you work on the settings. The assistant's on the other side, she look at you, the patient look at you, and then all as a team work together for this. It's important, because if you work in a place where the machine is on the other side, you never, with the time, the months and years, get used to improve the image. So you don't care, you are happy just pushing the catheter inside and releasing the embryo. So top quality, yes, but positioning that you can evolve the development in settings. So this is this kind of image is simplified, that if you are flat, if you change a little the angle, the gravity will bring everything together. So there are different kind of specialized couches, and no lithotom position. Usually the heels are at the level of the bottom of the lady. So basically you need to have a little couple of degrees upwards. Yes, we need to measure a couple of things. It's not just the endometrial thickness, fluid, but not just the fluid in the middle. You need to scan all the endometrial cavity, all of it, from one side to the other side, up and down. We need to exclude tubal pathology. We can, and I think it's a good idea to measure the length. The length, not only of the cavity, but the cervix. You know, there are long shoes and small feet, so it's not always the same. There can be a pre-even assessment that you need a longer catheter. So how you know that if you don't measure it? It's not nice at the last minute, oh, give me a bigger one. You have it there. And before, a couple of days, even before your embryo transfer, particularly the FETs, for example, if you're doing a normal cycle modified FET, you have done quite a lot of scans. So already you have the idea where you're supposed to go. So you can pre-rehearse yourself which will be the point where you want to go and bring these embryos. The other thing is using the cursor like I use. You can show to your assistant what you want to do. You rehearse as well before and during the embryo transfer, where she wants to be, what you want to see, where the image will be perfect for you to do it. So let's think about optimization. What is optimization? It's subjective, saying, well, I see better. Well, there are optimizations and optimizations. There are the black, blurred and bright like here. So if you follow all this, always your image will be better. So we have an idea that we have different fields. So you may decrease your angle of the field. What means that? Means that you bring more energy on the middle part, so better reflection, so you have better signal. You need as well to get used to with some filters, whether you use harmonics automated or other filters. The depth, you need to bring enough the depth so your image is holding inside of your angle, not part of it. The zoom and the focus. The focus, very important, I will show you in the film. So all this you will see in the videos. The cine loop, you can have 15-30. So you can get the timing right for the measuring of your effectiveness. When you have old models and absolute models, some people put 100 power. Power increase the artifacts. You do everything hyper-echogenic, so you are in a mess. Others, they put all that gain totally on the corner, losing the idea why we have the total gain and the separate gain. So we don't overexpose the image, so we need to individualize its time, but later on, if you are getting on this, you can have a preset, so you don't need to do all of it constantly, so you do the tiny modifications. So most of the colleagues don't know anything about that. They have the basic setting of a manufacturer, which is not done for embryo transfer. Okay, the other points here about the during embryo transfer. So yes, there is a communication. You have you show to your assistant where you want to go, how to move the cervix with the speculum, so you are ready. So it's good, the image. And then when you have finished it, you can measure the catheter tip or the bubble sign of the embryo sign positioning. Okay, so that was all of it. So now we can be more relaxed and we can see the videos. So here I will show you different kind of videos of embryo transfers. So this is what I call zoom video window. So these are the videos from the photos that are in the paper. So let's see what's going here. Okay, well, we have already passed the catheter. This is the uterus. This is a zoomed sequential image, meaning that we digitally bring a part of it. So that's the bladder. This is part of the speculum. And the idea is just to show that you go smoothly inside. I hope that the image is not too bright for you. We play it again. Where you will put the focus, it depends where you want. I mean, ideally under where you want to be, but you can be at the point of your point of interest. So it depends the lady. So you can be under or at the point where you want, and you can see if there's any change. So this is another way, so you don't give it any importance about the bowels, the rest of the bladder. You focus where you are. So focus on the uterine cavity. This is a different kind of video where you can see the deep ultrasound field, so you have everything. So the overfilled bladder, we have here the uterus, you have here, that's important to diagnose and to see the plastic valve, the edge of the speculum. Because what happens is, when you do it, you're a human being, you want to see the cervix when you put the catheter, and you have momentaneously, you lose your sight. I mean, yes, you start, but then you need to look and modify your tiny bits of your fingers and with the axis how you want to pass whatever catheter you want. So these are the areas that your assistant needs to show. In this field, we have a big field, so you can get the cervical part plus the uterus. But some people go only on the uterus. So the assistant can help you to bring more information about the intracervical canal. So for example, okay, we have already penetrated. This is the cervix here, if you imagine the external canal. A little of movement, slowly. Perhaps now I can see there is a little bit of obliquity here of the myometrium, but the point is that slowly you go in, and almost you are at the end. And we have deposit. I can't distinguish this one, and this one must be the little two embryos. So, I mean, if you have a very good image, you can see the flickering of the fluctuation of the fluid. It's not just the tiny bit, because that's the bubble. It doesn't mean that the embryo is there, but most of the times they are. So let's play it again. So a gentle introduction. You see there is not too many movements. the way that your assistant needs to learn is just to do this kind of ways of movement of the probe, very gentle, and never press too much on the top of the bladder because she's in pain. Imagine now that you have a fresh embryo transfer and you have a swollen ovaries and has an overfilled bladder. You don't feel very well, so you don't need to press. If you press, you have the impression that you increase the echogenicity because you squeeze, like elastography. So you squeeze the fact of the post-bladder enhancement. But actually, it doesn't really help you here. You have all the other instruments and modifications to help. So, for example, here I have put the focal area that I could see a little better in the rehearse stage, not at the last minute, because you do it, you don't have a third hand. So you can optimize a little bit before. Okay, let's move on. Yes, the retroverted uterus. Again, this zoomed sequential image. You can see that with the speculum in a way that can move a little bit the cervical canal upwards, we managed to have an alignment almost perfect like straight motorway. It's not always the case. The retroverted are always the worst embryo transfer that you can do. Let's play it once more. And okay, here is not the seconds, but you can, when you do the loops, you can write down how many seconds, what you have done, and so on. Okay, so the documentation with the videos and the Sino loops have a lot of information for your own training and evidence that you do what you're supposed to do. Now, measures post-ET, okay, another case here. Now, a big bladder, an anteroverted uterus, again, here, a way of the speculum. The introduction is here, and we go backwards a little bit slowly. Some people ask me if you wait. Okay, I mean, this is the practice that I used to do, at least in the UK, right? Because these are UK images of a good setting. Let's play it again. And let's put another image here. So when you finish it, then you can measure. For example, the two dots here, I think is about 8 millimeter and 5 millimeter. Okay, we are as close. That's it. You don't need to do anything more. So you can now verify the evidence of other colleagues, and as well you can say to yourself, well, I brought it more likely to the most common area of a success. So this detail is important. This is another image. This is not to show you a perfect image, but to show you a rare, in my opinion, a mirror image here, where you have a very bad echogenicity. Whatever we try to do, I couldn't make it better. You see the pixels here. You see the big sort of image of the catheter. Yeah, this is the embryo of the bubble. But for some reason, the machine doubled the speed, so created an image. So this is not true. I mean, it doesn't exist. So that's a pseudo image of endometrial cavity. So it's not detailed fish or anything like that. Allow me to talk about the proposed parameters for evaluation and how you can see you're improving on settings in the ultrasound. Yes, we need to have an evaluation. My dearest colleague talked to us about the questions, about how we do the OPU. Ariana and our group, we have talked about this technique, the other technique better, and evidence comes that we want some pregnancy rates. So pregnancy rates can be the first test and at least the 6 weeks. Others, they have even evaluated further. But why is it important? Because we need to know our effectiveness. What is your effectiveness? Personal effectiveness. Not mumble the percentage of XYZ IVF center we have been trained, or because we wrote and saw a paper. What is your personal effectiveness? That is interesting that nobody wants really to say what's going on. So we need to compare personal effectiveness, meaning total success. Yes, you can subdivide the groups of your patients, let's say top quality of embryos, normal uterus, 1 or 2 embryos, FAT. You can subdivide, but let's say that we have a way that we have a total effectiveness in FATs or single fresh embryo transfers, let's say. Well, that is changing with the time, but you need to compare if you work with a group, with a median, mean, of the operators group that you are with, and then always you will see that there is one operator that performs the best and one that doesn't. So you need to see the reasons why these people do that and the reason why where you are. And actually, it's important because this is the most neglected factor ever in fertility. When we do meta-analysis, we assume that we have the similar effectiveness. I couldn't find evidence about that. So if you have a product, A or B, whatever technique or the condition of ultrasound is good, when we do multicenter comparisons, what type of effectiveness have the operator? So we need to define that because we have a bias. Some people may have very good results and some are the bad. But we have put them all together. So their own influence is supposedly neglected or not very important. But I can't find evidence. There are papers saying that, look, we're fine between three of us, we have about 35% of success. Is that good? Others have said, no, our training process is so good, we have trainees that after 6 months, a year, they have top level up to 48 to 60%. Others, they say, no, we are about 40. So what is the limited that we need to find as a limited acceptable? What is the most common? And what they do, these perfect people, that they have fantastic performance. And you know what? I was lucky to observe them and be trained from one of them. It seems that the ability to have better ultrasound images help them to be much less traumatic, much easier to do. And that can be one question, maybe the ultrasound, if we take it so seriously now, that can enhance quite significantly the percentages of pregnancy. So research, we have to define who is experienced and how we define this, but as well we need to know what we're doing, so we need to evolve. We said that IVF evolves with the time, so supposedly our effectiveness. And this is not related, ladies and gentlemen, by the numbers of what you do. It's related most likely with your ultrasound ability. So I just mentioned you some results, so that's to discuss. 35% is something to be concerned of, it's something normal. Most of the units supposed to have 47, 50%, this that they have 60%, what they really do. I would like to learn and I will be improving my own self. And there is a conversion rate that is again neglected.
Just 1 minute.
I will come. That's for sure. Okay, Professor, fine. Because it's important to know what? To know how we can evolve. For the training purposes, again, we don't know. For example, in Moribor consensus 75, but in the experts more than 200, others more or less. Did we check the effectiveness of these trained persons? So the record keeping, to be short, is very important to demonstrate to your trainee the good cases, to analyze the difficult ones or the very good ones. You have valid data for medico-legal disagreement if in case, and certainly there is better patient experience because you can show her what you have done. She likes that to see what is happening. I hope that this can be a discussion for establishment through ESHRE, new guidelines about embryo transfer. It's not just we do everybody their way, we have to establish the guidelines. I propose some criteria for the ESHRE that you can see, and allow me just to show you, this is a very difficult case. For example, this one, you can see a very snapshot. It's during the process to evaluate this lady. What we have, a neighborhood gland, some intrafluid of secretion because of the estrogenic effect, and then you can see something here, what is that? And then you can see all these black dots. So I had a triple nightmare, which means I had a fibroid, that's an intracervical fibroid, which appeared during the stimulation, the previous stimulation, because it was an FAT. Let's move on. We have circumflex intracervical glands. These are not inodine, it's not simple. They can affect the penetration. In 3D, you can see that the fibroid is here, some glands, and you're supposed to do this with your catheter, but in three-dimensionally, so it's not just flat, it goes straight left and up inside, so it's like an S. Better image, for example, here, right? Stereoscopy pre, so we can cut this, and you can see these are sort of semi-pathological. We have these sort of glands adhesions, and these keeps the fluid inside, so you can see. So finally, a sort of optimized canal. And just to finish with this, this is a live sort of recording to see the real situation where, despite the precaution, there were, of course, some difficulties. And you can see that the catheter arrived here, and we have this fibroid. Of course, you cannot remove it. It's difficult, and you may create more damage. So you need to find a way to move on. And finally, after 2 attempts, these are with a rigid, with no embryos inside, in order that I can pass the stylet inside. And finally, we managed to be as close. But it was quite difficult. So the ultrasound can facilitate even potential, almost impossible sort of ways to pass it through. So I had 3 obstacles with me. So thank you very much. My email is there. I hope that we can collaborate, move on with guidelines, or anybody who wants and is so enthusiastic about it. This is an image of the god of Apollo. And actually, he is doing this sort of libation, we call it, giving some wine to the gods, hoping the best prosperity. So that's because of it's a photo from Delphi Museum, inspiring for the Delphi. These are the results from the Delphi, so I pass it through quickly. And this is from our colleagues here from Romania. The 2, I was very impressed from the museum in Bucharest. These are prehistorical pottery of almost 4,000 or 5,000 years ago. So you can see thinking, and then women may be even happier. Thank you very much for your attention.